Thank you for joining. I'll just give people a few more minutes to join us, not minutes, seconds rather. So we'll start the webinar in about half a minute. Hello and welcome to today's webinar on the future of healthcare. I'm Mia Hunt from Global Government Forum, the publishing, events and research business for civil and public servants around the world. I'll be chairing the webinar and I'm going to give a brief summary of what we hope to cover in the session before introducing you to our panelists. The coronavirus pandemic upended healthcare systems around the world, requiring hospitals and medical professionals to cope with a huge influx of patients with COVID-19. That focus meant that many routine operations and appointments had to be delayed, while lockdowns meant remote consultations had to be quickly developed or expanded. Now, many countries are facing up to a backlog of tests and treatments, but they also have a greater understanding of the role of digital technology in creating a more accessible healthcare system. So we'll be looking today at how governments are rebuilding healthcare provision post-COVID and what can be done to help future-proof the sector, with examples of innovation and best practice. There'll be a really interesting discussion, I'm sure, and we have a brilliant panel today who will share their expertise. We're going to start with short presentations from each of our three panelists, who I'll introduce you to in a moment, and we'll then move on to questions from you, the audience. So please do ask any questions that come to mind at any time during the webinar by typing them into the Q&A box at the bottom of your Zoom window, and we will get through as many of them as we can. Now to the panel. We have with us today Natalie Verdon, Director, Digital Solutions and Border Strategy of the Digital Transformation Branch of the Public Health Agency of Canada. Natalie has 20 years experience in the public sector and has worked in various government departments. She's been in her current role for nearly 18 months and helped implement solutions to support the Quarantine Act and the emergency orders issued during the pandemic. Also joining us is Nelly Labby, Director Secretary General, Innovation Policy at Estonia's Ministry of Social Affairs. The Ministry of Social Affairs is responsible for healthcare, social affairs and labour market policy. Nelly is motivated by the mission to increase the use of data in decision-making, for proactivity and for supporting innovation in public-private cooperation. And we have Adam Cutler, Deputy Director for International Affairs at Israel's Ministry of Health. Adam has very kindly agreed to stand in for his colleague, Dr. Asher Salman, Director of International Relations at the Ministry of Health. That's why you can see Dr. Asher's photo on screen. Asher is hoping, or was hoping, to join us between flights at the Heathrow Airport, but his flight may be delayed or he may have connection issues or something. So he's going to join later if he can, perhaps for the Q&A session at the end of the webinar. But we have Adam here to give his presentation and to answer questions too, so that's great. Thank you so much, Adam. It's appreciated. In case Asher can join, I'll run through his experience with you. So he's an oncologist and cancer geneticist by training, who has served in medical administration, management and policy for over a decade. He's a member of the Israeli National Health Council, and he also serves as an official representative for international agencies and bodies, including the World Health Organization and the OECD Health Bureau, of which he is a member. So we'll go to panelists for their opening thoughts now. And Natalie, we'll start with you.
Thank you, Mia. I hope you can hear me. So, hi everyone. My name is Natalie Verdon. I'm the Director of Digital Solutions and Border Strategies with Health Canada and the Public Health Agency. My role during the COVID pandemic was to ensure the safety of travelers and minimize disease transmission among Canadians. A bit of background. So the Public Health Agency of Canada administers and enforces the Quarantine Act and emergency orders made under it. It provides critical sets of services to international travelers who enter Canada, to ensure the safety of travelers and minimize the disease transmission among Canadians. These services include compliance verification with federal public health requirements and enforcement activities related to travelers, the quarantine plan, follow up with travelers about the development of symptoms and other information relevant to the containment of the infectious disease. The quarantine case management system that we launched in 2022 ahead of the pandemic and continued to evolve and develop during all the way through to the fall of 2022. The system provided the availability to support programs such as compliant and enforcement, compassionate exemption, regional operations, and testing. The system was developed under high pressure and rapidly implemented the case management system specifically for COVID-19. I'm going to talk to you a little bit today about the failures and successes that we actually had doing this. As most of us know, none of us was ready for a pandemic so large to be able to respond so quickly. So the initial response to the pandemic was made, what I call a mad scramble to synthesize tools that would meet the new digital needs of the remote government using pre-existing and available resources. Everything was done in a rush. There was less time to think and more time to action, which caused less integration with systems. This highlighted the areas of our existing online infrastructure that were unable to support the new capacity needed for the government in both the public health and the digital transformation sector. The shift to digital solution was highlighted gaps in existing data sharing and retention policies, as many of them were written with the expectation that the data was immutable. The pandemic led to an increased focus on cybersecurity as the shift of the remote work and the online digital solution increased the potential for exploitation of vulnerabilities within our systems. Several data feeds for one data set utilized for borders crossing, for example, from a CBS Canadian Border Services Agency. There is at least 3 different feeds that were coming in, data management and duplication of following other government departments using policy and standards created by themselves and not integrated with what the public health required. So what does that mean? It means that the data couldn't be trusted as the policies were different. It was captured without proper authentication of travelers. There was huge data delays in ensuring that we had the information required. And not to mention the fact that we had lots of dependencies on other government departments to be able to support us and help us get the information. We also had some challenges with several different departments sharing data and having information from a traveler perspective. So a lot of travelers were very confused as to where they had to put data and information coming in, which caused issues for us. So we had to fix the back end so that it was more seamless for the Canadians. Other challenges that the teams had was you had multiple projects and multiple requirements on the go. So sometimes juggling several different things were very difficult for a lot of resources within the federal department. We also had several meetings as a lot of this was very urgent to be able to turn over. So it was less time to work on deliverables. So that all sounded very negative, but let me talk to you a little bit about what the successes were of being able to do this. So the increase of demand for online services accelerated the adoption of a more modern technology such as video conferencing, remote work tools. Government adopted remote work in an accelerated timeline, which was huge for us. As some of you may know, in the government, we don't always work as fast as in the public sector, so this was great. The ability to hire people across Canada to allow remote work assisted in the gain of expertise needed to move quickly with the evolving technology. We had orders in council associated to the Quarantine Act that were approved and accelerated by Parliament. This was great for us. We created a partnership with the Canadian Border Services Agency, Health Canada, and the Public Health Agency of Canada at a working level, sharing information. It was integrated, it was great. We also had to partner with external labs nationwide and coordinate specifications with them. This ensured that the traveler didn't have to wait for a test result for long times and matching of the traveler record. All data was digitally received from 5 major labs, and the system was able to match the traveler record. Oh, sorry, I repeated myself, not sure why, terribly sorry. But we were able to match it up with the system to be able to ensure that the traveler could move forward. The ability of traveler data in real time allowed for users to quickly search and populate data fields, reducing the lineup at the borders. As you all know, media action and media attention regarding travelers and borders was blamed on doing testing. I would say, I would beg to differ. There was a lot of different factors for that. There was, illnesses with pilots and illnesses with folks at the borders, but there was also testing. So I think it just compounded throughout that process. So in conclusion, what I'd like to leave you with is, now that we understand the importance of having a system to deal with such events, and are now moving forward with plans to develop the next generation of case management system through the electronic traveler health information. At this time, it is expected that the Public Health Agency will examine multiple solutions and consider all the information provided when determining what system will be best for the potential future. We are also understanding how much we require other government departments. I didn't have enough coffee this morning, I'm terribly sorry. Partnerships, I made it one word, to be able to move us forward. That will help us in our lessons learned to be able to create something great for all travelers, and also understand what's happening with any type of pandemic or infectious disease troubling Canada. Thank you.
Thank you very much for that, Natalie. So yeah, interesting to kind of think about it from a sort of facilitating safe travel point of view. The considerations like cybersecurity and data sharing, acceleration of digital adoption, cooperation between public bodies, and sort of embedding the lessons learned as well. So thank you very much for that. Nelly, we'll come on to you next, please.
Hello, very pleased to be here. Although the subject not so nice, but I think if you look for one good thing that came out of the pandemic is the sort of accelerated learning from each other that we are doing right now. I'm really glad that this hasn't stopped. But yes, my main purpose in the Ministry of Social Affairs is actually to support integration of the 3 domains: social services, healthcare, and employment. And maybe you can go on with the slides. And I believe every country has seen some sort of similar effects of COVID, and so do we in Estonia. The tree is a sort of Estonian national dashboard. All our national strategic goals are represented as the leaves. There's a branch for every field, and the one in color is for healthcare. As you can see, it's not so spring or summer color, but more like fall colors. So red ones are the ones that we are not doing fine. Actually, some of the leaves were red even before the COVID, as for example, obesity. But with some goals, we were doing steadily going to the right direction, and the COVID effects are on the statistics. For example, life expectancy has gone down. Also, amenable deaths and preventable deaths unfortunately have risen. And to my the saddest point that I find in all the statistics are the issues with mental health. Suicide among the 10 to 17-year-old children actually rose like 3 times. Of course, the numbers are small, but every child counts. So this is terrible. Suicide attempts in general went up, and even the number of mental and behavioral disorders are also gone up. So nothing nice about this. I'm gonna go to the next slide. But when we think what really happened during the pandemic, then actually Estonian healthcare was fully digitalized before COVID. So for us, it was more like a reality check or a test period. We have a national health information system that includes all health data, and it is supported by different tools like Medical Images Bank, also a national one, patient portal. All the prescriptions are digital, not all the prescriptions. I think it was 97% of all prescriptions are digital. And we already had some narrow AI support systems and the first e-consultations between the specialists. Not knowing that the pandemic is going to happen, our healthcare insurance fund took up in January 2020 the plan to introduce telemedicine also for patient contact with doctors. Until that time, we were quite sure that this is one thing that we will not digitalize. So we valued human contact there. But well, then the pandemic happened. This telemedicine took up really fast. Other COVID additions, of course, the national COVID application. We had some learning moments with the international certificate, because Estonia introduced the digital certificate about a month before European Union, and then we had to redo it again. We found out that we need to look at whole new data sets that we hadn't even considered beforehand, like number of contacts for patients in or people in nursing homes, or personnel who work in more than one healthcare institutions. This was not something we considered before, and getting this cross-domain data was a challenge. But I think the most noticeable innovation actually didn't happen in the medical sector for us. It happened in the borderlines of medical sector. Especially we see it along mental health issues, and also in context with education. We have several private sector companies rising up and getting awards all over the world. So they took the situation, and as the worst point of the pandemic was not in healthcare sector, was not in educational sector. They had more opportunity to innovate. I just suggest this is one of the reasons. I think we can go to the last slide I have prepared. When I thought about what we are doing for the future, then actually I found out 3 things that we're not doing. First of all, this was not one crisis. This was not just a pandemic for Estonia. At one point, we had 3 major crises simultaneously. I mean, the COVID crisis was still on, and the Ukrainian war started, and we had refugees coming to Estonia, which we had never experienced in that extent beforehand. And not long after, we faced the energy crisis. All of them affected the healthcare sector as well as the social sector. So can't really prepare for one healthcare crisis, but you have to be more general. You can't really prepare also by integrating more of the medical sector possibilities, but we have to integrate along different domains. For example, when the issue is with hospital beds, then probably we can't get any more beds within hours or days. So the only possibility is to transfer This is where social care needs to be integrated more than we ever thought of. As I heard someone say that the mindset of healthcare providers needs to be shifted from the hotel mindset to the airport mindset. Also what we found out that we can't do everything together. So prioritization 2.0, we are refiguring everything. Also because COVID shifted the funding of the medical sector. Somehow we have to deal with the backlog. So can't do everything at once. So everything is on the table again. So this is my short presentation.
Thank you very much for that. So yeah, sort of the effects of the pandemic in Estonia, aspects like mental health during and after the pandemic, digital healthcare, remote or virtual doctor's appointments, facing multiple crises, shift in mindset needed, and funding considerations as well. So thank you very much. Adam, you next, please.
Good afternoon. Thank you. My name is Adam Cutler. I'm the Deputy Director for International Affairs at the Israeli Ministry of Health. It's good to see colleagues on the line. I know that the collaboration we had from Estonia and from Canada was particularly useful, as well as the UK. So thank you for that. I was asked to discuss the backlog and recovery of the health system, looking back at the COVID crisis. And I just want to open with a brief description of the ministry and the Israeli health system. So the ministry acts as a regulator for a system that serves about 10 million people, consisting of 4 HMOs or sick funds that provide universal care to all residents nationally. So one of the things that was particularly beneficial going into the crisis was the level of digitization that already existed. We have the HMOs competing with each other to begin with, and they tend to compete on customer service and on accessibility as they compete for members. So each of the HMOs has a digitized app, has a electronic medical record system that is compatible across a national health information exchange system. And that was particularly useful throughout the pandemic. What we didn't have was the interconnectivity to serve for real-time data gathering on a national scale. We needed to develop that during the pandemic, in order to create a real-time situational awareness for decision makers. At the beginning of the crisis, we were gathering that through phone centers and calling up each health facility. And towards the end, it was mostly automated. We did a couple of things very early on that I think prevented a backlog in a significant backlog, I should say, in health services. For starters, we enabled telemedicine, doctor's visits very early on. The infrastructure was already in place, but our regulations were not. And we needed to adjust those regulations in order to enable doctors to bill for telemedicine visits in the same way that they would bill an in-person visit. And that was particularly helpful in keeping a backlog from developing. Also, with the exception of the first lockdown, we didn't prevent our hospitals from performing elective surgeries and procedures. This was developed with a sort of a flexible understanding with the hospitals, who at the end of the day have to answer to us as the regulator. But while we did stop for the first short lockdown elective procedures, we enabled them to continue as long as they maintained enough spare capacity for any changes in the direction of the pandemic. So in that sense, when we look back at the pandemic, we're back to our usual waiting times for health services. They still exist. There are still waiting times. There were before the pandemic, but largely they're back to where they were, and we're always looking to improve, but we're in a much better position regarding wait times than many other countries. So we're relatively happy for that. What do we have to rebuild to truly recover from this pandemic and to build a system that's better prepared? I think the first aspect that's really taken a beating throughout this crisis has been public trust. That's not to say that that we've betrayed public trust. I think we made the best decisions that we could with the information that we had as we went through the pandemic. All countries did. None of us, with 2020 hindsight, I'm sure there were some decisions that would change, but for the most part, decisions were made in good faith. That said, they took their toll. The restrictions took their toll on the economy, on people, on relationships, on mental health, and all of that causes an erosion in trust. And we need to rebuild that, to pay attention to growing anti-vax movements, and to be responsible stewards of the public's trust going forward. The next thing that we are working to do is to build cooperation among countries, to build sort of an early warning system and the tools so that they're available for the next pandemic. That includes situational awareness and real-time data collection. That includes agility to make and implement quick decisions. It includes the ability to innovate quickly and roll out those innovations in the field, sharing information internationally, which is absolutely critical in foreseeing or giving yourself a little bit of time to prepare before a new pandemic arrives. And of course, rebuilding that public trust, engaging with the public, and engaging in counter speech where we encounter fake misinformation, rather. The last pillar of that preparedness, I would say, falls under healthcare resilience and ensuring that our systems are flexible in responding. One example is just the ability to expand the number of hospital beds in our facilities temporarily. Our hospitals are well trained for that in the event of war, and certainly we made good use of that capacity during the pandemic as well. I think that's my answer. Thank you.
So yeah, interesting to hear about the kind of digitalization that happened that existed in Israel before the pandemic. The HMO is focused on customer experience, data gathering and automation, preventing a significant backlog in elective procedures, preparedness, public trust, the need to rebuild, combating misinformation, and resilience as well. So thank you so much for that. Plenty of food for thought there from all three of you. So we'll move on to the Q&A section of this webinar now. If anyone watching has any questions that you'd like to put to the panel, please do type them in the Q&A box at the bottom of the Zoom window, and we will get to those. I'll start with one of mine, and this has been touched on, but I want to dig a little deeper. To what degree did COVID prove an accelerator for digital transformation in healthcare, and how do you keep momentum going? You know, is there a danger that now we're not in the midst of the crisis, that things kind of slow down a little bit and lessons are forgotten? Natalie, we haven't heard from you for a while, so I'll come to you on that first, please.
Thank you. So to what degree? So I'll tell you from an accelerator perspective, it was really interesting to watch the government departments come together, Parliament make rapid decisions, being able to move digitally away from paper. So unlike my colleagues on the air, some of us still had paper-based. They didn't see the importance, but COVID made them understand that there's an importance in them. I mean, the government departments in general, and as you know, we're just workers within that. How do we keep momentum? That's really interesting. We've been having conversations at the senior level regarding this. I do believe that just because the pandemic is over, and I'm going to air quote that, there's a lot of different things that we should be tracking and viewing, and we should have preparedness, early warning system. I completely agree. We need to look at how we can deter this and make Canadians' lives a little easier. All travelers, I talk about Canadians because I'm a Canadian, but anybody coming into the country and going away, how do we start understanding where an infectious disease is coming from? And it's not just infectious diseases, we also have drug issues, we have suicide, all of these things. We need to monitor them better, and we need the governments on whole across the world, I think, to not forget about what happened in the pandemic and be able to put a really big spotlight on that so that we can move and we have better momentum and we are bringing ourselves in the 20th century, because I don't think this is the last pandemic we'll ever see. Thank you.
Thanks. Nelly, would you like to come in on that?
Yes, I think it was definitely an accelerator for some developments, but on the same time, some other developments were postponed and are just now picked up from drawers again, and we are starting to think about it, how to move on with all the ideas that we had. In the long run, did it really change anything? We have had those discussions that perhaps in the broad picture, it didn't really change things. It just shifted the time when something was ready or not, and how to keep the momentum going. I think the need from the public pushes us to keep the momentum going. Our people are desperately waiting for any kind of personalized services. We need to deal with the backlog. Everybody wants everything to be smooth and unseeable from the government perspective. So I think they are the way we keep going.
Thanks. And Adam, question on acceleration, momentum.
Sure. I just have to reiterate what Nelly said, which is resources were shifted, some changes were accelerated, some were not. People saw a new priority for health in general, and I think that will have a long-term effect in terms of shifting resources. In our case, we saw regulation enable telemedicine visits, which remained in place, thankfully. And I think people are responding well to that. And at the end of the day, it's our job to ensure that our regulation isn't stifling innovation. A lot of the innovation will come from our startup ecosystem, which has taken the responsibility and charged ahead with innovations.
Okay, thanks. And Natalie, you mentioned sort of the need to sort of monitor, and you've all spoken about data, so I wanted to come on to that. Just how important is data for monitoring, for analysis of healthcare trends or citizens' experience of healthcare, and for making improvements, for informing decision-making and policy, and how do governments and countries ensure that data gathering and analysis is done to best advantage, I suppose. So Natalie, I'll come to you first on that one as well.
That's an interesting question. I feel like I'm on a hot seat because there's a lot of different ways to respond to that, but I appreciate the question, Mia. So data from people, data from countries, data, especially from travelers is super critical for us to understand what's coming. Being able to share that information, understand that information, create data analytics for that information, being able to synthesize that information will help us be more prepared in the future. So we've already started doing that. We're collaborating with other government departments. I talk about that a lot because government departments do speak, but it's not necessarily sharing of information in a rapid response as we did during the COVID. So it's quite critical to understand, where travelers are going, what countries they're seeing, what's happening, but we also have to keep the lines open with other countries. So, we have Estonia and Israel on the line and the UK, and that information is really important to us as well. So if they understand that something's coming a little bit early, that we get that information so that we can start monitoring as well to ensure that we can start reporting or at least seeing what the actions are internally before we go out to the external public. That's what I have, Mia.
Okay, Adam.
I think data is absolutely critical in sort of three main areas. First of all, handling that data safely, securely, and in an anonymous fashion is absolutely critical for doing the kinds of research that can really leapfrog us into a medical era where personalized medicine and more pinpointed early detection is possible. So that big data era is critical, and we need to know how to handle the data, build up the databases in a safe manner. Second of all, early detection, seeing the trends in the population, even if it's not related to a crisis. As we see trends shift, we need to shift around medical resources, train more in a certain specialty, whatever the case may be. Having that data on a national level is indispensable, and in a crisis, all the more so. Having a national picture, good data that you can rely on to guide decision makers can really be a question between life and death when you're talking about national policies. So I would just say very important all across the board.
Nelly, would you like to answer that question as well?
I would even go further and say that data is the only solution that will help us tackle the backlog, both in healthcare and in all the developments that are left behind. I think the only way we can actually deal with this is to introduce new services based on data, and which can deal with the healthcare backlog. And also we are having trouble with the numbers of doctors, not enough workforce in the healthcare sector. We can't do enough in that matter. The best thing and the quickest thing that we can do is to reduce the administrative burden of all the medical stuff. And it has everything to do only with data. And of course, as Adam also mentioned, the point we are going to is prevention, which is also based only on data. So the only solution.
Thanks very much to all three of you for answering that one. Focusing on data sharing and collaboration, I mean, we know that can often be difficult between government departments within a single country. But have you seen since the start of the pandemic, during and since, that countries are collaborating more on sharing data so that they can kind of foresee, better predict the next kind of global health emergency and deal with it as effectively as possible? Is that something you've seen, and is it being sustained? Adam, I'll come to you first, please.
Sure. Yeah, I think throughout the pandemic, we saw sort of both extremes of that factor. We saw countries collaborating, sharing information, alerting when new variants were out, sharing treatment methodologies, sharing basically every kind of information that could be helpful, and that was tremendously helpful. We also saw countries hiding data, hiding trends, underreporting cases, which made it very difficult to understand how the virus was moving globally. I think many times it was a matter of capability, just simply not having the capability to test and to build up the data sets, but it was particularly when you started having countries designated as red or green, there was an incentives problem with reporting as well, and that created some problems.
And Nelly.
I would say that Europe has been quite busy with enabling data sharing cross-border, and we are currently already sharing e-prescriptions and e-health records with several countries in Europe. Next in pipeline are medical images, and also for a broader context, the European Health Data Space Regulation, which maybe will be ready in the end of this year, will set new rules within Europe to change more precise data with all the countries in Europe.
Thanks. And Natalie, would you like to come in on that one?
Sure. I think the challenges that we do have is the legalities, so the Privacy Act, the Information Sharing Act. There's several different regulated acts and rules across countries. I don't know what, I don't presume to know what they all are, but I do think information sharing at a higher level of understanding where hotspots are is critical for all of us, and that we should be able to move it forward. But it can be proven to be a challenge, even just across Canada. I've talked to you guys about other government departments sharing information and how they manage. Everybody has a different policy. It's not one standard one. I know other countries may have a standard one, and they're a bit ahead of the bell curve of Canada, but we don't. So it's a challenge. I'm hoping that this pandemic has identified that challenge and will allow us to share information. A little bit like Adam too, we did see a lot of people holding the information close to their chest and not really reporting. It could have been due to technology restraints or the ability to track these different pieces of information. However, it would have been great for us to understand it before it became, from a yellow or a green to a red immediately, and that's how some of the information was coming in.
Okay, all right, thank you. I want to move on now to talking about remote doctors' appointments and consultations. Obviously, in a lot of countries, that was something that hadn't ever been done before and had to be kind of rolled out very, very quickly. I'm not sure how it is in other countries, but in the UK now, it's much more common to have a call with a doctor than to see them face-to-face at the surgery. And it is a voice call rather than a video call usually as well. And I think there's a perception that although it's perhaps reduced waiting times for doctor's appointments, that the quality of care isn't quite as good, especially for maybe elderly or vulnerable people who would benefit particularly from seeing a doctor at the surgery face-to-face. So I wondered what your thoughts are on how you ensure that the quality of care doesn't drop if these remote services are to continue. Nelly, I'll come to you first on that one, if that's okay.
Yes, I just looked at the statistics of where the number of telemedicine visits is right now, and it's about 10% of all the visits. But yes, the same as in UK, mostly they are phone calls, but assisted then with the data. So I think the main tool do not change the quality of the visits is that it's a free will possibility for all the patients. The doctor can never suggest that you must have a video call or phone call. It's always a possibility to actually have the face-to-face visit, and the way people prefer to do it, and there's enough quality in that. Also, of course, we need to measure it and as every time.
Okay, so people always have a choice. They might have to wait a little bit longer, but they can see a doctor face to face if they wish to. Okay, Adam, how's it in Israel?
Sure. So I'm not an expert on telemedicine, but I'll tell you my impressions, which is that people do still have a choice, as Nelly said. It's the doctor's in his office, his or her office, either way. Many of them occur on the phone. I think particularly what it's doing is driving access to care. It's access to care for working parents who might not be able to bring their child in. It's access to care for people with limited mobility. It's access to care for people who live in the periphery. So we do have phone visits, we have video visits. There are devices that some people have which enable some basic tests at home, whether it's taking someone's blood pressure or whatever. These are connected devices that the doctor can access. And in some cases, even if you're in the periphery, you can come into an HMO clinic that's local to use that device to consult a specialist further away. So I think the real advantage of this will be driving better access to care for those who need it.
Yeah, so there is that convenience factor. And talking about accessibility, how do you ensure that people who aren't digital natives or who don't have stable internet connection, for example, aren't left behind, and that healthcare services become more accessible and not less so? Adam, I'll come back to you on that one first.
Sure. So first of all, we have very tight-knit families. So if there's someone who is perhaps a bit more elderly and less comfortable with technology, usually their family is there to take care of them. It's one of the things that we pride ourselves on, that the closeness of the family. And the flip side of that is that we haven't done away or reduced any physical services. Those options are still available. And we do have whole populations, even beyond the elderly, who do not engage with the vast majority of technology, do not have internet in their homes. So it's important for us to keep those physical services open and accessible.
Natalie or Nelly, would either of you like to come in on that one? Natalie, I'll come to you. You're nodding.
I can. So there's challenges. We too, a lot of the families are, take care of the elderly, and they're, with us at home, so we can support them. I use my mom as an example. She's 85 years old, and so technology is interesting. She calls Facebook Foosbook, and she'll goggle it instead of Google it. And so God bless her. She does really try to do technology. But from a broader standpoint, what I'd say is we have a lot of different facilities that permit the elderly to go into, social services facilities that you can go into. You can go into libraries, you can go into hotspots, and the technology is available for you there, and you can ask for support and help, and they can do that. So if you are a person who's elderly, or a person that's not technology savvy either, I mean, we target the elderly, but some people just don't want to do tech, and that's okay as well. There's a lot of different facilities within Canada that you can go into and ask the question, and they can help you. The concerns with that is sometimes people don't like sharing their information because it's private information. So often what we do is we just ask them to put an email address in, and then the rest that they can populate on their own when the person is away. So we do have those.
Thank you. And Nelly, the Estonian perspective.
pretty much the same. Although Estonia is very scarcely populated, then the internet and network coverage is pretty good. And after the COVID, almost every grandma on the street is having a FaceTime call. So, but yes, if there is someone who's, if they really want to have a digital meeting and not go to the physical one, not have the phone call, then they as well can go to libraries, to social departments. I think everyone will help. We haven't had any complaints about accessibility in this regard.
Okay, so that all sounds quite positive. We've spoken about the backlog in care. Some countries, the backlog is huge, and in other countries less so. It was perhaps better dealt with during the pandemic. But where there is a backlog, how do you ensure that next time there's a pandemic or similar, that routine elective operations and procedures can continue? I mean, I know it depends to some extent on the country and the government and the kind of setup between the different bodies. Natalie.
From a Canada perspective, I think we've learned that we need more resources. So I don't think we neglected our hospitals or our healthcare providers. I don't think we neglected them. I just don't think we had enough of them. And the pandemic proved that when you have an influx, you need to be prepared to do a rotation. The mental health toll that it took on our healthcare providers was huge, which also created a backlog, right? It's not just the pandemic, the amount of people that were coming in, or the illnesses, or the surgeries that we were having. It's the inability to have more folks being brought on board in a short period of time. So like a surge capacity, right? And I think a lot of, I don't want to speak for any other country, but I know Canada has realized that. And we are now looking at different ways of onboarding the nurses and doctors, looking at credentials from other countries, and how do we respond to that? How do we bring them back into the country faster, as opposed to making them re-educate themselves or having their credentials recertified, all within paying attention to, you know, our legal laws, making sure that these are the appropriate way to move forward. So I think those are the stopgap measures that Canada is putting in place. It doesn't mean it will resolve everything, and we still do have a backlog. So I'm not going to pretend that we don't for elective surgeries and non-critical surgeries. There's still a backlog that's happening there.
Nellie, you've talked a little bit about this, I know, in your presentation, but I don't know if there's anything that you wanted to add.
I think I will add just that after having the experience of 3 crises at once, and the 2 ones originally not in the healthcare sector, but still affecting greatly what is happening right now. We are doing enormous amounts of drills of everything possible that could happen simultaneously in one region, in all of Estonia. So exercising pretty much. I don't know whether we will be ready, but because we don't know what will happen and how many new crises at once. What else could you do?
Yeah, and Adam, is there anything you'd like to add as well?
Sure, I'd echo what Natalie said, which is basically we need more resources. We need to build spare capacity. We have some surge capacity, but in Israel, at least, we run a particularly efficient health system, which has its drawbacks. It means that we are running without spare capacity. It means that burnout is high. And we desperately need to be investing in that spare capacity in order to maintain preparedness. Drills and investing in preparedness and resilience is obviously important as well. Those are largely components that we had already addressed, but that spare capacity is critical.
Yeah, I was going to ask about things like AI chatbots, for example, and automation. Is that part of the answer with those kinds of services that can answer questions, for example, about quite common conditions, taking over from humans and allowing people to do kind of more complex work in other areas? I don't know whether any of you have a view on AI in healthcare in future and what that could mean for capacity, for example. Would anyone like to come in on that one? Nelly?
Yes, I actually checked out just before this webinar how many AI solutions we already have, and directly affecting medical stuff, maybe 5 or 6, and some new coming. For example, some tools like decision support for doctors that suggests that maybe you should do some lab results which haven't been done for a while, or you could go on with this plan data viewer, which looks from all the data that we have in Estonia for many years already digitalized. It takes up a quick picture of the most relevant health issues and sort of interacts for the doctor very quickly. Drug interaction assessment tool. So while prescribing new drugs, the system will analyze which drugs are already being used and will there be any metabolic interaction there. And Previsit, also sort of the question answer tool that quickly suggests to the patient the best way. Can you deal with this at home? Should you go to your GP? What are the possible solutions? And some new ones coming also, like pharmacogenetics and so on. I think, yes, as I said, I'm a great believer of data and the possibilities it gives to us. Then this is the best way to deal with the backlog, to use more of what we have.
Yeah, it's a very interesting area. Interesting to see how it develops. We might get back to this, but Asher has joined us. Asher, are you there? Can you hear us okay?
Yes, I'm here still on the aircraft with a major delay to Heathrow. So I can hear you, but to speak, I guess, in 10 to 15 minutes.
Thank you very much for joining us. I know it's probably a bit of a...
I'm so sorry for missing it. It was really a pity for me. All of this today was quite a problematic day, but I'm sorry, and I'm sure Adam did his job.
It's great to have the both of you here, and that's a bonus for us. So Adam went through some sort of opening comments at the beginning of the webinar. I don't know whether there's anything that you want to say now, anything that you wanted to emphasise before we go back to questions, Asher. Asher, I just wondered whether there's anything you might want to emphasise, or
he mentioned he's still on the aircraft, so I don't think he's able to really speak from there.
Sure, we'll just have him listening in, and if he is able to answer any of the questions, then we can do that. So I'll go back to AI then. Adam, would you like to tell us your perspective?
Sure, I'll echo what Neely said, which is basically decision support is critical. I think AI will take a huge role in assisting physicians. I don't think we're at the stage of replacing physicians yet. I think it will help in decision support, diagnostics, particularly around medical imaging, and speeding up that process. And I think we have a counter trend which is working to create more of that work, which will mean that we're still reliant on doctors and need more and more of them. I think you have an aging of the population, you have increase in non-communicable diseases and chronic conditions over years. You have early detection, which means that you're managing those diseases for extended periods of time. And all of that, I think, means that doctors will be secure in their careers for a long time.
Yeah, okay. And Natalie, AI? Question for you.
It's an interesting one. So, AI can help with the triage of patients, I think. So the early triage, what I mean is they're calling in and they're informing of it. I echo what Nelly and Adam said, that there's not much more I can say about that. But I do think AI will play a huge part in data sharing, though. Like AI will be a lot more rapid to be able to understand what are the trends that are happening, how we can possibly inform and share that. So I think that is a huge component of where we could actually go with AI, more than replacing nurses or doctors. I think the ability of having to be in a room, so I'll echo what Adam said, is super crucial, especially with patients that are very ill or requiring immediate attention or emergency attention. I'm not sure how AI would ever replace them, but I do think that they can assist them, right? There's a huge difference between there, and maybe I'm wrong. I think maybe we'll look at the video in 30 years and somebody will say, look at that girl saying AI couldn't do it, and they could. So if that is it, then I'm okay to be wrong today, 30 years from now.
And I think this kind of ties in perhaps with trust, which Adam, you spoke about in your presentation. You know, we've seen trust, as you mentioned, waning in countries around the world. There are many reasons for that, but sort of concerns about privacy and AI play into that a little bit. And looking back kind of at the beginning of the pandemic and in the midst of it as well, countries perhaps didn't predict the level of controversy that there would be around vaccines and the mass protests and the misinformation and disinformation around vaccines as well. So how do you start to build public trust in governments and institutions so that the next time there's a big health emergency, that perhaps they're more compliant or kind of understand how measures being put in place are designed to help them and protect economies, for example? Who would like to go first?
I'll take that one. I think trust has eroded. It's been the result of fatigue with all of the restrictions that have been in place. We do see more and more stronger anti-vax movements, more questioning of authority. I think the path forward is a path of transparency. It's a path of data sharing. One of the things we developed midway through the pandemic was sort of a national dashboard with more and more real-time data that was available to the public throughout. I think it's rebuilt through counterspeech and not through censorship. I think censorship is probably the wrong approach to misinformation, but rather through counterspeech that is transparent and comes from messengers that inspire trust. So it's a long process. There's no magic bullet.
No. Okay. Natalie or Nelly, would you like to talk about trust? Natalie, I'll come to you.
Sure. Public trust is always a challenge. So I do believe in being transparent, identifying information rapidly, trying to help folks understand what they're getting into, what they're putting into their bodies, how this all works. You'll never get 100% compliance. You'll always have people being people, and that's okay, right? You believe what you believe, and you need to move forward with that. But government as a whole needs to be more transparent, help them understand, and we have to know that I think we built a bit of trust and we broke a bit of trust. It was quite interesting from 2020 to 2022. And I say that because I believe we built trust in the sense that we were telling people, here's what you have to do. You have to, stay at home. And a lot of countries were trying to be transparent, and it was hitting us faster than we were able to respond or turn around. The other part of that is we lost a bit of trust because, people had adverse effects to what they were putting in their bodies, and then the rumor mills started, and that you can't stop. And media and information is so rapid nowadays, across everywhere, across the world, right? Like if I want to know what's happening in Israel in real time, I get to know that in Estonia too, and so that proves to be a really big challenge for a lot of us to be able to implement across the board, and no matter what department or what you're doing in life, right? So again, I agree. I think public leadership on being transparent, informing as early as possible, giving out the information is what will help us build some trust.
Yeah, and Nelly.
Difficult issue, actually. In Estonia in general, the public trust toward government and our e-government is higher than on average in countries. And I think more we have to keep the trust. So in that matter, we need to create more value that people can actually feel, see. And I also hope that we don't fail there, that we will be careful with introducing AI solutions, and that we don't fail with data protection. These are the things that we try to keep up. But of course, you have some divergent groups as everywhere, but there's also the data that could help us interact with those groups in the way they want to be talked with.
Yeah. Okay. So I think we have a few minutes left. Probably time for one last question. So I'll make it quite a broad one. On the future of healthcare, really, the topic of this discussion. What do each of you hope for the future of healthcare? And what could it look like in, say, 10 or 15 years' time? Natalie, I'll start with you.
What I hope it would look like: rapid response times, more information sharing, true transparency, better ability to collaborate countrywide, so truly countrywide, in early stages, right? So information sharing acts, information sharing period should be reviewed and understood. We do have policies and procedures, and I do know that across all different kinds of countries, and we have shared information. It's like we hold it to our chest, but more on that. Also, public trust in provincial governments, federal governments, all governments. I get it. It's not always easy for us. It's not always easy for the average person to put their trust in what the government is deciding, but I would like to see that. Thank you.
Thanks. Nelly, over to you.
I hope that we can use all the possibilities that are available right now to actually support the shift from reaction to personal prevention. So all these problems we're having today will be smaller, and that we will be, yes, of course, on the way. It won't be easy because the direction from reaction to prevention, sort of on the way you have like double job. You still have all the patients coming in, but you also need to do new things for prevention, that we can somehow make it easy for the medical personnel along the way. So we can at one point see ourselves in this preventive healthcare.
Thank you, Nelly. And Adam, your final thoughts.
Well, Nelly, you took the words out of my mouth. I think the major thing, it's a broad question. If I have to give a broad answer, the major thing is a shift from treating illness to prevention and early detection. I think that's a shift that we'll have to make, and we're beginning to have the tools to do that. So that would be number one. And I really think that is the main thrust of trends at this stage. I think also I'd like to see more emphasis on mental health. I think we saw how difficult and painful that was throughout the pandemic, how many people suffered, not necessarily from acute conditions, but everyone could use better mental health and mental health management. So I'm hopeful that we'll see physical health and mental health as part of one package and address it accordingly.
Thank you very much, Adam. So that is where I will draw this webinar to a close. I'm sure you'll agree that we've had some fascinating insights there. So thank you very much to our brilliant panel, and thank you again, Adam, very much for standing in last minute, and for Asha for joining us for the last few minutes there and listening in. And of course, you, the audience, for watching. You'll be receiving a recording of the webinar in the next few days and a written report on the topics covered in the next few weeks. Before that, though, there is a survey that should be in your inbox now to get your thoughts on today's session. And it'd be really helpful for the team here at Global Government Forum if you could fill that out to make sure that we're providing the best possible content. And also any ideas on topics that you would like to see us cover in future would be welcome. We have a whole host of webinars coming up. One of them taking place on the 15th of June is called Purposeful, Experiential and Digital: How Public Sector Tourism Strategies Can Adapt to Today's Traveller. This will cover how tourism authorities can leverage digital technologies and data to respond to travellers' evolving needs and preferences, and how governments can unlock tourism as a growth driver for local economies. If you'd like to see a full list of the webinars we have planned over the next few weeks and months, head over to globalgovernmentforum.com to the homepage and click on webinars under the events tab. So once again, thank you everyone very much for joining today, and we hope to see you at another of our webinars very soon. Enjoy the rest of your day.